Good afternoon, everyone. Today we are discussing the webinar on use of antigen test kits to control COVID-19, and this is supported by various institutes: the National University of Singapore, Sri Hock School of Public Health, Health System Research Institute, the Ministry of Public Health, National Research Council of Thailand, the Access and Delivery Partnerships. Next, please. I would take some minutes to discuss the general announcements. The meeting is being recorded, and we hope that it will be useful later. We have simultaneous language interpretation between Thai and English, so please feel free to communicate in both Thai and English. And sorry for Singapore, we don't have Chinese or Malay, so please speak in English. And the intervention, if you have, please rename yourself to indicate your organization and name, and please indicating when you want to speak by raising your hand, preferable at the end of the presentation by the speakers. And feel free to use the chat box to post questions or to participate in discussion. And as the courtesy to speaker, please unmute when you are not speaking. Our objective today is to learn about the use of antigen test kit or rapid antigen test under the living with COVID-19 in Singapore. And we hope that we identify potential lessons from Thailand during this meeting. The agenda is begin from 1 o'clock to around 2.5 o'clock, and it begin with 10 minutes opening remarks by Dr. Somsak Chunharat. He is President of National Health Foundation, our respectable researchers and policymakers. And then we have an overview of COVID-19 situation and response in Singapore by Dr. Lee Yang Chu, Vice Dean of Global Health and Global Leader of Infectious Disease, National University of Singapore. After that, Dr. Alex Cook, Associate Professor and Vice Dean of NUS, will discuss about impact of using ATK to control COVID-19 in Singapore. Then we will have around 30 minutes for discussion between various Thai organizations about the ATK. And then we have a short summary and remarks. So for this opportunity, I would like to ask Dr. Somsak Chunharat to give his opening remarks. Thank you.
Thank you, Dr. Sulakamed, and good afternoon, Dr. Lee Yang Chu and Alex, our colleagues from Singapore NUS School of Public Health. I'm sorry I could not open my video, but that's all right. I hope I will switch to Thai because the majority of the participants are Thai. But before that, let me thank our Singaporean colleagues for taking the time to share their valuable experiences from Singapore with us. I'm very sure that with the leadership of the medical science department, we will have lots of interesting questions, practical ones, as well as some of the more theoretical, conceptual as well. And we certainly hope that the lessons from Singapore would be useful for our application here in Thailand. Let me switch to Thai. สวัสดีทุกคนนะครับ ผมเองก็ยินดีนะครับที่มีโอกาสมาเรียกว่ามาร่วมประชุมครั้งนี้กันเลยกันนะฮะแล้วก็ได้ถือโอกาสให้พูดอะไรสักนิดหน่อยผมจะพูดในภาษาไทยก็อาจจะดีนะครับเพราะมีแปลภาษาอังกฤษด้วยนะครับโดยส่วนตัวเนี่ยผมต้องเรียกว่าเป็นกลุ่มที่เรียกว่าอะไรล่ะเป็นพวกที่ไม่ค่อยมั่นใจว่าสิ่งที่เรียกว่าrapid test เนี่ยนะหรือ widespread testing เนี่ยมันจะอยู่ตรงไหนในกระบวนการควบคุมโรคนะครับถ้าพูดกันสั้นๆก็บอกว่าเหมือนที่เราไม่ได้เกริ่นไว้เนาะมันมีประเทศสัก2 กลุ่มเนาะกลุ่มนึงก็บอกว่าไม่ได้มีเคสไม่ได้เลยอีกกลุ่มนึงก็บอกว่ามีเคสก็ไม่เป็นไรเนาะ เรายินดีจะมีเคสจำนวนหนึ่งเข้าใจว่ากลุ่มหลังเนี่ยก็จะพยายามใช้หลักที่ว่าถ้าหากว่าเกิดมีเคสขึ้นมาก็รีบแยกรีบรักษานะครับซึ่งผมเข้าใจว่านั่นเป็นเหตุผลที่ทำให้การใช้ rapid test เนี่ยกลายมาเป็นเครื่องมือสำคัญนั่นที่จะทำให้เกิดสิ่งที่เรียกว่าการรู้ตัวเร็วรักษาเร็วนะครับซึ่งก็แน่นอนนะครับผมที่จะเป็นวิธีคิดที่น่าจะเป็นวิธีคิดหลักสำหรับประเทศซึ่งอยากจะอยู่กับโควิดให้ได้นะครับอย่างไรก็ตามนะครับโดยส่วนตัวเนี่ยผมเองก็สนใจเรื่องนี้มากแล้วก็ถ้าหลายท่านทราบเนี่ยในช่วงหลังในอย่างน้อยในฝั่งของประเทศไทยเราก็จะมีข้อมูลที่ว่อนไปอยู่อย่างน้อย2 อันนะครับอันหนึ่งมาจากหมอในประเทศไทยเองอีกอันหนึ่งมาจากหมอที่ประเทศอังกฤษที่พูดทำนองว่าถ้าธรรมชาติของโรคมันเปลี่ยนไปนะก็คือว่าวัคซีนก็ป้องกันการติดเชื้อไม่ได้นะ variant ใหม่ๆก็ยังสามารถที่จะทำให้ผู้คนเนี่ยติดเชื้อได้อย่างทั่วไปนะทั้งที่มีอาการและไม่มีอาการนะครับพูดง่ายๆก็คือว่าโอกาสที่จะทำให้เชื้อมันหยุดแพร่นี่น่าจะยากมากนะครับการตรวจ ATK เนี่ยมันจะมีประโยชน์ในมุมไหนมันเป็นประโยชน์ระดับปัจเจกหรือเป็นระบบระบบพูดง่ายคือถ้าเราใช้มันจะช่วยทำให้เราคุมโรคได้ดีขึ้นหรือไม่แค่ไหนเพียงใดนะครับแต่ที่อาจจะยากกว่าคือสมมติเราเชื่อว่ามันคุมโรคได้เนี่ยเราต้องทำไปนานแค่ไหนแล้วเราจะใช้สิ่งที่เรียกว่าตัวชี้วัดแบบไหนเป็นตัวบอกว่าเราควรจะดีหยุดได้หรือยังนะครับที่มูลนิธิทรัพย์สินแห่งชาติเนี่ยคุณหมอก้องเกียรติเกตเพชรนะครับซึ่งไม่แน่ใจว่าวันนี้มาร่วมประชุมด้วยหรือเปล่าก็มีเรียกว่าอะไรมีฉันทะนะครับไปทำสิ่งที่เรียกว่า outreach ATK testing ในชุมชนผมก็เลยถามแกบอกว่าในฐานะเป็นคนที่สนใจทำเรื่องนี้เนี่ยคิดยังไงแกก็ยกตัวอย่างประสบการณ์ของลิเวอร์พูลที่อังกฤษซึ่งเป็นประสบการณ์ช่วงก่อนเดลต้าจะแพร่หลายนะครับที่พยายามจะบอกว่าเนี่ยเราสามารถจะเทสจนกระทั่งประชากรเนี่ยติดเชื้อน้อยกว่า 2% ได้นะครับถ้า 2% เมื่อไหร่ก็หยุดเมื่อนั้นนะครับผมก็ตั้งคำถามว่าจริงหรือเปล่าเราจะมีโอกาสได้เจอติดเชื้อ 2% ไหมเนี่ยแล้วถ้าเจอเนี่ยปล่อยไปสักพักหนึ่งหรือว่าหยุดเทสมันจะกลับมาใหม่ไหมแล้วจะเริ่มต้นใหม่ยังไงจะใช้อะไรเป็นอินดิเคเตอร์อะไรทำนองนี้นะครับก็เลยดีใจมากนะครับที่คุณหมอยศได้ส่งประสบการณ์สิงคโปร์มาแล้วก็ดีใจมากกว่านั้นคือหมอสุรเมธกับทีมนิคมวิทย์ก็สนใจที่จะเรียนรู้จากสิงคโปร์ก็เลยถือโอกาสมาเรียนรู้ด้วยกันนะครับก็คงจะสรุปว่าจะรอฟังนะครับแล้วก็หวังว่าพวกเราทุกคนที่อยู่ในฝั่งไทยเนี่ยนะครับจะช่วยกันตั้งคำถามแล้วก็จะได้ช่วยกันมองเรื่องภาพของการใช้ ATK เนี่ยอย่างเรียกว่าอย่างครบวงจรอย่างต่อเนื่องระยะยาวทั้งระยะสั้นและระยะยาวที่จะใช้ประโยชน์กันยังไงนะครับก็ขอให้การประชุมประสบความสำเร็จด้วยดีนะครับสมตามเจตนารมณ์ที่มุ่งหวังของทั้งฝั่งผู้อยากรู้กับผู้ที่มาช่วยให้ความรู้กับพวกเรานะครับlet me conclude by thanking Singaporean colleagues again. I was telling our Thai colleagues that we hope that this session, although short, would be very useful to guide us both for the immediate actions as well as long-term policies and help us devise some kind of decision-making tools and decision-making criteria based on experiences in Singapore, and I'm sure that elsewhere as well. But we will be trying to pick your brains from the Singaporean experiences as much as we can. Thank you very much once again for Dr. Surakimet and the Medical Science Department team for organizing this, and for to our Singaporean colleagues for agreeing to share the experiences. And I look forward to the fruitful discussions and fruitful applications in our Thai context. Thank you very much.
Thank you very much, Dr. Somsak Chunarat. Next, in the agenda, we will move to the information from Dr. Lee Yang-soo. He is Vice Dean of Global Health and Program Leader of Infectious Diseases, Swee Hock School of Public Health, National University of Singapore. He is going to give us the overview of COVID-19 situation and response in Singapore. Please, Dr. Lee Yang-soo.
Hello, everyone, and thank you very much for giving me the chance to be here. I'm very privileged to be able to share a little bit about what's been happening in Singapore to you. Let me start up my slides here. I'm not able to share my video for some reason, but hopefully we'll see each other in person sometime. So as mentioned, I will talk about what's happening in Singapore, and do feel free to ask questions because I'm going to go very generally in view of the time. So I think right at the start of the year, at the end of the last year, Singapore had a 4-pronged COVID-19 strategy that involved around enhanced surveillance and looking for cases, and containment in the form of either hospitalizing or isolating all the COVID-19 cases we can find and quarantining all their contacts. We also have an active case finding strategy with contact tracing, the use of technological surveillance such as Trace Together to try to find out more contacts so that they can be quarantined. And then finally, we reduce the importation because that's primarily the way that COVID-19 is introduced to Singapore. But we were always aware that this was a very temporary strategy because Singapore, unlike many other countries, is small and dependent on trade and cannot be shut away from the rest of the world forever. But all these strategies were not very effective once the Delta variant came to Singapore, where it appeared sometime in April this year. And we had outbreaks in our airports, we had outbreaks in hospitals, and really what it did was to show us that the prior strategies that we had to try to keep COVID numbers as low as possible was not going to be effective. And I just show you this quick little charts of the situation in Singapore. At the start of last year, April, we had a lockdown because there was the spread of the virus through our migrant worker dormitories. And then when this came under control, we kept the numbers down until the Delta variants arrived in April 2021. And at that time, we were in the midst of stepping up our vaccination, at the same time allowing people to return back to the community, allowing dining and other forms of less restrictive measures. So in this chart, you can see that our vaccination rates as of today is about 81% of the entire population having received 2 doses of mostly the mRNA vaccines, but also Chinese vaccines such as Sinovac and more recently Sinopharm as well. And 84% of the population have received at least 1 dose of the medicine. But even when we had vaccinated 80% of the population, when come 10 August after the National Day, when we started to step down the restrictions again and allowed people to dine out in groups of 5 persons, allowed people to visit and socialize more often, and increase the number of people that can attend mass events or go to shopping malls, you can see from the chart on the right that the numbers started to jump up in the community. And this is again a final shots at the situation in Singapore. You can see that over the past week, the number of cases have started to go up to the extent that quite a number of people now require hospitalization, oxygenation, although the number of people that require the intensive care unit care still remains low. So we have gone up to several hundred people a day. I believe yesterday it crossed the 600 mark for the first time, for the longest time. And the breakdown of the cases is what you can see. So at this point in time, all these different complicated restrictions in Singapore have continued, right? So for people who want to dine out, they can dine at most 5 per group, and either everyone must be vaccinated or the children, because they can't be vaccinated, must come from the same household. For hawker centers, only 2 persons can dine together. And you can see that there's a whole long list of restrictions that actually makes it extremely difficult for our small and medium enterprises and the small businesses to survive. And this has led to quite a bit of unhappiness at the slow pace of rollout. But at this point, the current strategy, even with 81% vaccination, is to try to increase the outreach try to go for the last mile vaccination, especially the elderly who cannot be vaccinated. At this point, Singapore has not made vaccination mandatory for any group, including the elderly, but we're trying to reach every single last person. And we're also thinking of giving a third dose or booster dose to those who are most vulnerable, those who are immunocompromised or elderly. And I think maybe like Israel, we'll think about giving the third dose to the entire population, but this is still controversial at this point in time. Previously, as I mentioned, we used to hospitalize all the mild and asymptomatic cases, but now because of the rising numbers, which our measures are not able to control, without being more strict, our hospitals and our COVID care facilities will overflow if we keep trying to isolate them outside their home. So from yesterday onwards, we have started to allow the mild and asymptomatic cases to be isolated at home. And as my colleague Alex Cook will mention, we are still expanding testing as a strategy. And we have gone from PCR tests over the past year to greater emphasis at antigen kits and self-testing. Of course, I think we all understand that the antigen kits are not very sensitive compared to the PCR tests, but because they are cheap, there is a rapid turnaround time, and they're quite convenient. So we have given the kits out to all the households, and they're also available for sale in our different pharmacies. You can buy them over the counter, for instance. And although we understand that the majority of people, if they test positive, they might not even report it at all, but we hope that enough of them, when they test positive, will stay at home, and that will slow down the spread of the virus. So at this point, because we are not confident that 81% of the population being vaccinated is sufficient to prevent our healthcare system from being overwhelmed, what our ministries have done is to try to slow down the reopening, try to expand testing, and most importantly, to see what's happening in other countries, to see whether or not Singapore can open up more, right? In particular, we are looking at what's happening in Israel, in UK, and in Denmark. Denmark, I think this week has opened up entirely and removed all its restrictions. And they're a small country like us, with also an 80% vaccination rate. So I think we'll have greater confidence to open up once we vaccinate more people, as well as see that nothing bad is going to happen to Denmark in the coming weeks. So this last slide of mine just shows the different effectiveness of the vaccine. And we know that the current COVID vaccines are actually protect against severe disease, but don't protect so well against mild disease. So most of the vaccines, especially the mRNA vaccines, there's an observation of a waning immunity over time and with new variants. And the idea of the third or the booster dose is actually to try to shift it more, to try to prevent even the asymptomatic infections as far as possible. But I think this is something that we don't have enough data on yet, and we will have to see what happens in Israel and US and other countries that have instituted the booster dose to find out what is happening. And I will pause here, and feel free to ask me questions, or you can wait until Alex has also presented. Thank you very much.
Yes, may I ask? Thank you very much, Dr. Lee Yang-Shu. This is a very interesting overview of disease control in the COVID disease control in Singapore. May I ask some questions from participants? Not yet a questions showing up, but I have one question. There is one question from participant, but let I put my question first. I observed that in the dining setting, it seems that Singapore don't allow unvaccinated people to dine in the restaurant. Is that right?
That's correct. We used to have a more complicated formula, more complicated rules, but now we have a much simpler one. And there are a lot of measures that differentiates between vaccinated and unvaccinated people. So for dining in restaurants, Everyone has to be vaccinated, and they can only dine in groups of 5. The children, like I mentioned, are unvaccinated, but they can only dine with their family members. In our hawker centers and coffee shops, because it is very hard to enforce the check on vaccination, only 2 persons can dine out, and it doesn't matter whether they are vaccinated or not.
So it seems that you concern very much on dining in the restaurant. Is there previous outbreak based on the dining?
I think off and on there have been outbreaks in restaurants, fairly small ones in Singapore, but I think all over the world we see examples where people spend a long time eating and talking with their mask off in a confined space, and that is where the highest risk of transmission happens. So those are the situations that we have in Singapore. And there are rules that I didn't mention, including how many people can sit together within a room of certain sizes. So that's also under a form of controlling how crowded a restaurant or an area is.
ดร.คำนวณอาจารย์คำนวณครับรบกวนอาจารย์ถามนะครับมาถึงอาจารย์เห็นก็ยกมืออ๋อครับ
He put his hand down.
allow to talk อาจารย์คำนวณ
ได้ยินไหมครับ
ได้ยินแล้วครับอาจารย์ครับ
Okay, thank you so much, Dr. Lee. I have 2 questions. The first one is that it is unexpected to see the rising number of, I want to use the term moderate to severe cases in Singapore, those who need oxygen supplemented. Your curve show that the number increased maybe double when comparing to the previous time. I wonder what are the characteristics of this group of people? Are they elderly, or there are those with underlying disease, or there are general healthy populations? That is my first question. My second question is that what are the vaccination strategy in Singapore? Do you have prioritized some particular group? Thank you so much. Over to you.
Thank you very much for your questions. Let me answer the first one first. So the majority of the people who require oxygen or are in ICU are unvaccinated people who are above the age of 50 years. The risk of unvaccinated individuals who are more sick with COVID-19 is almost 10 times more than the vaccinated individuals. And I think this is the figure that has made us very concerned with the virus spreading around in the community at greater numbers. As for your second question, I've lost your second question.
The vaccination strategy. You have
okay.
already group.
Thank you. Yeah, so initially when we had supply issues with the vaccines, what we did was we vaccinated the healthcare workers first, followed by the elderly, and then we just went down the age groups, right? So the elderly first, and then those above 50s, 40s, and so on and so forth. Now it doesn't matter. There are no issues with the vaccine supply. So anyone above the age of 12 can make an appointment and get vaccinated in Singapore. For the booster dose, for the third dose, again, we are only going to do it at present on those who are immunocompromised, those with cancer or transplants, or some other, or even the very elderly, those who might not mount such a good immune response against the original 2 doses of the vaccine.
There is additional questions from the chat box.
Okay. maybe I can tackle them as we go down. So
yes,
yeah. So the first question for the test, antigen test kit that Singapore plans to use as the current strategy, do you have plan for coverage of active surveillance? And how about the frequency to test? So in general, Singapore doesn't have overarching strategy on that. The test kits are just made widely available, and different companies and workplaces may choose their own strategies of testing. For instance, our hospitals, our healthcare workers, the hospitals have policies where every 2 weeks they may go for a PCR test, but then the week in between, they will need to do a self-antigen test. 1 or 2 hospitals have gone all the way to doing self-antigen tests every week. In the university where I'm from, we are asked to do a self-antigen test kit for every 20 days that we go to the university. Well, that's the university policy. So you can see that there is no standard in that regard, and the government has more or less left it to the hospitals and the company as to how they want to test to prevent the spread of COVID-19. The next question is, what is the specificity and sensitivity of the RTKs used in Singapore, or are there a range of tests being used? Okay, at the last check, we have more than 5 different antigen kits being used in Singapore. I think the SD biosensor is probably the one that is most widely available, but all of them are similar in the sense that the sensitivity is about 80%. Alex Cook probably has more data on this that he'll share later, but the sensitivity is maybe about 80% as a whole, probably higher during the first few days of symptoms and much lower after the first week. The specificity is about 99%. Next question, how do people prove their vaccine status before using these facilities? I don't have a camera or I can show it to you, but in one of the apps that we have, the Trace Together app, the vaccine status is also present there. And this can be shown to either the person who checks at the door, or there are detector devices that you can put the Trace Together device on, and you will register a signal if the person is vaccinated. Also, you believe tests to find the infected cases will impact the outbreak? This question I will leave to Professor Cook to discuss, because he has some very nice models to show that they will reduce the transmission of COVID-19. Is there any study showing the effectiveness of COVID-19 to control, the RTKs used to control COVID-19 in Singapore? I don't think we actually have a formal study, but we have some mathematical modeling results that Alex Cook will show you as well. Okay, I think that's all the questions in the chat box.
Thank you very much, Dr. Li Yang. I'm sorry that I asked you to do my job. Okay, so I think we can move on to the next presentation, and then if we have additional questions, we can ask after that. But I think Dr. Li Yang has to leave. So anyway, if we have questions about the overview of the policy, we can ask him later by email. The next presentation is from Dr. Alex Cook. He is Associate Professor and Vice Dean of Research at Sir Swee Hock School of Public Health, National University of Singapore. He will talk about the antigen test in Singapore. And please, Dr. Cook.
Okay, thank you very much. And I'm sorry, I also cannot share my video. So the first thing is I want to declare a conflict of interest, that my research team has received research funding from a large medical device manufacturer called Becton Dickinson, and they produce antigen tests and PCR tests. So obviously they want me to say that tests are brilliant in order to boost their sales. I'll try to be as neutral as possible though. Okay, so there's 2 things I want to talk about over the next 20 to 30 minutes. So the first is how Singapore is currently using antigen tests, And this is going to build upon what Li Yang spoke about just now. And then I will talk a little bit about models that we've been developing to look at the possible impact of antigen tests. So first, I'll take you through a little bit about how Singapore's stance towards testing has changed over the last year and a half. I think that Singapore still has a very pro-PCR mindset. In 2020, at the beginning of 2020, we relied a lot on PCR testing. And then later in 2020, we started to combine PCR testing with serology for some specific use cases. So let me explain some of the way that we were using testing historically using PCR tests. So for suspect cases at a GP clinic, when we had enough capacity, then anyone who has a respiratory illness, apart from younger children, would get a PCR test. Early in the pandemic, we didn't have enough capacity, and so it was just at a subset of general practice clinics that they got that. Contacts of a case, when they went into quarantine, they would get PCR tests at the beginning and the end of the quarantine. And that was to mop up any infections that were missed as part of the contact tracing around about confirmed cases. We have done some mass testing events. So last year, when we moved out of lockdown towards the reopening of schools, at that time point, because there was some worry from parents of children about the risk of the teachers being infected, so we did mass testing of preschool, so nursery or kindergarten teachers, before the schools reopened. Now, one of the problems actually with that is that when you do mass testing of asymptomatic individuals, after you've had community transmission, you can find quite a lot of hidden infections that have already recovered from their disease. And that's something that we found when we started doing serology testing on them. So you do PCR positive, but then they're also serology positive. And that means that they're probably recovered, but there's still fragments of virus up the nose. And so that's one of the issues that we face with the mass testing. We've been using testing at the border. The borders have been somewhat restricted for the last year and a half. Like, for example, I've not left the country since the Prince Mahidol Award last year. But when people come into the country, they will get PCR tests. And that's both when they arrive as well as when they leave the quarantine. And then, as Liang alluded to, we also have regular testing of high-risk groups. So healthcare workers, some of our foreign workers in dormitories. Here's a photo of some of our foreign workers lining up because they're going to get their fortnightly PCR test. And that's to stop the big outbreaks that we saw in the dormitories last year. Now, one of the other problems that we faced was at the early phases of the epidemic, we didn't really have enough testing capacity. And I'm going to show you what the number of tests per case looks like for Singapore, Thailand, and the US. You can see at the beginning of 2020, Singapore actually had one of the world's worst testing rates per case. I think it was around about 3 tests for every positive case. And that was because we didn't have enough capacity to test all of the foreign workers when we had the large outbreak. And so since then, we've been ramping up the testing capacity. So actually now we've got quite a good number of tests per positive case. Okay, so that was what we were doing last year. What I think has shifted a little bit this year is that antigen tests have become more accepted, but these have mostly been as an addition to the PCR testing and not as a replacement to PCR testing. So the confirmation of cases is still from PCR, not from antigen. So I think that's a reflection of the traditional mindset. PCR is gold standard, it's got a high sensitivity, we should use that for the confirmation. So let me just talk you through some of the ways that the antigen tests are being used to date. So one of them is at the border. So I'll show you a diagram here. This is the most recent big change to our border strategy. There's 4 categories of countries now. And as you can see, for post-arrival repeat testing, while they're under quarantine, for the higher risk source countries in categories 3 and 4, they're to take antigen tests on day 3, 7, and 11. That will be while they're in the hotel, getting their quarantine before they're allowed out into the community. So they'll be taking antigen tests. Note, they're still doing PCR tests to exit from the hotel quarantine. And they're also doing PCR tests when they arrive into the country. So the antigen test is in addition to that. Okay, so that's one of them. I think also quite recently, we've shifted to doing 2 tests for every suspected case. So if you go to the GP, you would get an antigen test and a PCR test. So the rationale for this is if you're antigen positive, you know straight away to send this person for isolation. This is before we started home-based isolation. If they're antigen negative, then you send them home while they're waiting for the PCR test result. So we're doing twice as much testing because of this, but it means that we have a bit more confidence that we're not sending people out into the community while they're actually infected. So the third is for the regular testing. So I showed you before the men lining up. So they were getting testing once a fortnight, so once every 2 weeks. And that was very effective in stopping transmission from the period of August last year until the last month or so. What we're doing now, I believe, is that they're getting PCR tests 1 week and antigen test the next week, then PCR test and antigen test. And we're now experimenting with allowing them to go out and socialize outside of the dorm. And before they do that, before any visit to the community, they have to do an antigen test to show that they don't have a high risk of taking infection with them. Okay, the next one is for mass events. So Singapore's trying to reopen to things like conferences and so on. And so for these mass events, antigen tests would be used. I can give you an example of this. That is that we have started doing cruise ships that they leave from Singapore port, they go out into the water for a few days, and they come back to Singapore port. And without going anywhere else, not going to Malaysia, Indonesia. And so before passengers are allowed onto the cruise, they do a test, which can be either antigen or PCR test. So there's 2 big companies that do it. One of the big companies, sorry, is doing antigen test actually when they get to the docking place, the port. So here's one of my PhD students about to get his antigen test. And then the other company is using PCR tests at 1 or 2 days before. There's a shift towards VORT, vaccine or regular testing. It's a terrible acronym. And so this is that people who are not vaccinated are expected to do more tests. And actually, our university, as Liang mentioned, now has mandatory self-testing for all the students and staff. And I'm going to show you what the app looks like for that. So we've got this app on the right-hand side that we need to show whenever we come onto campus, if we want to go into a shop or we want to go into a building on campus. And that shows that you are allowed to be on campus that day. And there's an option there for the fast and easy tests that you can see. So if you're if you're vaccinated, like I am, then every 20 visits to campus, you have to do one of these antigen tests and take a photograph within the app to show that you are negative. If you're unvaccinated, you've got to do a test every 5 days. So basically once a week if you come into campus every day. And the Ministry of Manpower has been pushing for more companies to do this, so to have workplace-based testing in order to reduce the risk of infection at the workplace. We still have quite a lot of people working from home rather than working from offices. Now you can buy over-the-counter antigen tests. So at the weekend, I actually went shopping to buy one. I got an Abbott Panbio test at a pharmacy. I bought these in the past from supermarkets. It costs about 280 baht for a single kit. And you can buy them in sets of 10, for example. And so our university is making these available for our staff and students for free. But you can also buy one if you don't want to go to the university pickup point. And the government is sending out a small number of these to all households so they can take part in things like regular testing. And there's an argument that we will be starting to do quick test centers, so that if you want to attend an event which requires you that you've got a confirmed test, you could go to the quick test center, maybe in a shopping mall or something, get a quick test and get that registered onto your phone. So I'm going to show you this is the national app that is most people will have, and it shows your vaccine status, but also it will have a test status as well, and that will come out, I think, later this year. So I want to just reiterate that still PCR is considered to be the gold standard, but the antigen test is being used to supplement on top of PCR testing in order to try to find people earlier and encourage them ideally to go to primary care to get tested for real with the PCR test, or at the very least to stay at home and isolate by themselves and avoid infecting other people. So that's the first part of my part of the presentation. What I'd like to do now is to talk a little about some of the modeling work that my team has been doing. And I'll just reiterate that this is the modeling work we're doing together with Becton Dickinson, the manufacturer of tests. So we've been looking at how we can use models to try to assess what the possible impact of different testing strategies. And I want to talk about two different kinds. First, strategies around about the travel and reopening the border. And second, strategies about testing in the population, so the community, for example, the testing we have at university. But we'll start with travel, if that's all right. So our view about testing around about the border is that it's like an additional layer in a filter to try to filter out some or many of the infected cases from getting through to the general community. This was especially important back when Singapore was pursuing a low COVID strategy. So Singapore is not pursuing that anymore. And I think that over time, it's likely that our border measures will be relaxed quite a bit. But at least over the last year, the stratified approach to dealing with the border has been very effective in keeping spillover cases from travelers from reaching the general community. So the idea of modeling is it allows us to look at different combinations of the pre-departure test, on-arrival test, what kind of test it is, how long the quarantine is, when you do testing during quarantine, to work out what percentage of people will be missed by that strategy, and then to decide whether that percentage is too high for the policymakers' comfort. So we have been, I'll show you a little bit about how we make the model when I talk about community testing, but we've looked through literally hundreds of different scenarios for what kind of tests are done and when the tests are done and how long the quarantine is. I'm just going to give you a bit of an overview of what that looks like through a small number of tests. Like I say, we've got hundreds of them, and if you want any combination that we haven't done, that you want to have done, you can let us know and we'll do it. So here we're showing what happens if you're doing on arrival PCR, exit of quarantine PCR, no testing in between, and no testing before travel. And we're looking at different durations of quarantine from 3 days up to 2 weeks. And so we run this through the model, as I'll describe later how we do it. And then what pops out of the model is what proportion of infections that would be completely missed out of, let's say, 10,000 travelers. So it would range from 17% up down to 2%, depending on how long the quarantine is. So for example, if you're infected just before you travel and you only got 3 days of quarantine, there's a very good chance that we would miss you, because even if you do a test at the end of the quarantine, you're still not going to test positive. Now, how does that translate into an absolute risk for our people? So how we think of this is that we imagine a fixed number of travelers. And this is the approach that Singapore government has been taking. I realize other governments will take a different approach, but the government has kind of set a budget almost. This is the maximum number of cases that we will allow to come in from overseas, and they back transform to work out how many travelers, how many planes will they allow to fly in order to not get too many cases. So here, what we're imagining is that we've got 10,000 travelers in total. And so of those, if the prevalence in the source country is 2%, that means you've got 200 travelers on those planes. If the prevalence is 0.15%, it means you've got 15 travelers on the planes. So we can work out then how many absolute number, total number would be missed from any of these source countries for any of the different strategies. And then the government can look at these numbers and say, well, our tolerance is that we think that we can get 5 cases come in from the border out of every 10,000, but not more than 5. So if that's the case, if it was really 5, then you'd say for the high-risk source countries, you must have 2 weeks of quarantine. But for the lower risk source countries, you'd be fine with just 3 days or maybe even no quarantine. Okay, so that's one slide. I'm going to show you what happens when we replace the PCR tests with antigen tests. You got to look carefully though, because the numbers don't change very much. I'm not sure if you could see that. So there's a small change to the percentages. We know that the antigen test is not as sensitive, but the reason it's not as sensitive is because if you just do one test, there's a good chance you'll miss. But if you're doing 2 tests around about the beginning and end of a period of quarantine, there becomes more opportunities for you to pick up a positive, an actual infection. And this is something that not just from our model, but other models which have looked at less sensitive tests have suggested that frequent testing can make up for the lack of sensitivity. Of course, that's good for the manufacturers. It means you can sell more test kits. Okay, so how does this translate into routine testing in a population? So let me try to explain how the model structure works here. So we're thinking of individuals going through a series of tests. If it's routine testing as part of their work, then this might be testing once every 2 weeks, or once every month, or once every week. And so if they are infected, then they would have to be infected between 2 of these tests. And so we can work out when the onset would be, or the distribution of onset times, or if they're not actually symptomatic, a pseudo onset, which is similar to the onset for someone who's symptomatic. And then from that, we can work out how long it will be until they would get detected and therefore get isolated by looking at the sensitivity of the tests as a function of time. And I think this is a very important point, because actually a lot of the manufacturers' results just show an overall sensitivity. They don't show what the sensitivity is as a function of time, but it's really important to know that if you're trying to work out how long it will be before you're able to identify a case. So what I'm showing you on the bottom left as a sensitivity, I just want to give a bit of a caveat to that. So the PCR test, this is from people, symptomatic people who are identified in a longitudinal cohort in China, and they got repeat testing with PCR. I can give you the reference if you want. The antigen curve, this comes from us in US analyzing some data from Becton Dickinson, the manufacturer that produces the test. And so it's based on patients who were PCR confirmed and then also had antigen testing. And I want to give you a big warning that the before onset for both of these involved some guesswork because there's not a lot of test results before onset. Okay, now, the last time that I spoke to HITAP and MOPH, there was some worry that the antigen test curve that we're using here is too optimistic and that the experience in Thailand as the antigen tests may be less sensitive. So we can reanalyze any Thai data on antigen tests you've got from the tests that you've done and reduce the sensitivity and rerun this analysis. It's quite straightforward to do that, and we're willing to do that if it helps. Okay, so how it works then is that we can work out how long it would be until, what the distribution of time until we can identify cases, and then use that to work out how many infections would have already happened from that case by the time you find the case. Right, so if you find them very early, you can stop 90% or more of the infections. If you find them after 2 weeks, no point, because they've done 80% of all the infections that they're going to do. So then we can work out how much the effective number of secondary transmission, how much that would get reduced by. We want to try to bring that down below 1. So here's the main table from this, and I'll wrap up in a minute. So we're looking at different frequency of testing from daily to monthly to none. And we're looking at what happens if that repeat testing is done by PCR or with antigen. And as you can tell, antigen is not as good as PCR. But the difference between them for the same frequency is not that much different. Monthly testing is pretty useless because it only reduces transmission by about 20 to 30%. Weekly testing would be very effective. So it would reduce transmission by somewhere between 80 to 90%, we think. Daily testing would be amazing, but probably too expensive. This set of results was developed for an unvaccinated population. Now, the experience that we've got from our clinical cohorts in Singapore has been that vaccinated individuals shed virus for less, probably about half as much as the unvaccinated cases. And it's not clear, we've not adjusted the model yet to account for what would happen in a highly vaccinated population. I do not think that my university's approach of giving a lower testing frequency for vaccinated cases is going to have any effect. I think that we should use the same frequency for vaccinated and unvaccinated, because we know that vaccinated cases or vaccinated people can still get infected. Okay, so from the last part in the modeling, and in particular with regards to the border measures, if you want to know more, the paper that we published is the QR code is for that, and we can give you a link later. So if it's a low COVID setting, not like Singapore or Thailand, but maybe somewhere like New Zealand, then the amount of spillover from travel, you can carefully calibrate that for good use of testing and quarantine. For a zero COVID setting, then you must be very careful and you would want to have a very high bar to enter into the country. For a low COVID setting where you think that you can control outbreaks, which is what Singapore thought we had last year, actually did have for most of last year, then you can calibrate the amount of spillover from travelers into the community through this kind of model. For high COVID setting, which is like Thailand just now, or like Singapore is becoming, spillover from travel, actually, I don't think is very important because the proportion relative to community transmission is probably quite small. Therefore, I think that we can be more tolerant to missed cases. And what we want to do is basically just reduce down the amount of infections from the travelers. Although antigen tests are not as sensitive as PCR, the difference becomes much smaller when it becomes part of a bundle of tests and quarantine. So when you're taking tests a week apart or 2 weeks apart. And so the advice that I would recommend, again, conflict of interest, you take my words with a pinch of salt, is that you would use the test which is more practical rather than the one which is more sensitive. So for example, if, I'll show you again Singapore's strategy here. If you want people to do the test by themselves while they're in a hotel, and you don't want to send like a nurse to go along and swab them, then antigen tests would be more practical. If they're all at one point, like they're arriving at the airport, then you can station a nurse there. There's no harm in having a PCR test. And they're going to go into quarantine anyway, then the delay to get the test results doesn't matter either. So you'd be able to use a PCR test in that case. Right, so you use a test which is more practical for the situation. That's what Singapore is doing just now. I think that for low risk ports of entry, ports of departure into the country, actually you can reduce the quarantine length substantially. And that's something that Singapore is doing with places like New Zealand or China. So I'll stop there and I'll take any questions. Thank you.
Thank you very much, Dr. Alex Cook. I would lead from the chat box first. And currently there is a question. Do all ATK products available in the market in Singapore has been equally accepted by relevant authorities requesting for the test, for example, university or airport authority?
Okay, that's a very good question. So thank you for that. So I think that all of the tests need to get regulators approval before they can be used. I don't think there's a large number of tests in the market. And I'm just going to take a quick look to see which ones we can use for NUS. So my university allows us SD Bio, Abbott, QuickView, BD, Becton Dickinson, and then supposedly others, but I'm not sure how the others, how that works. It's not listed as an explicit category. So certainly when I've been to the supermarket and pharmacies looking for test kits, it's only really that small number, 4 or 5 different manufacturers. I know that there have been some moves to try to use other forms of testing, such as a breathalyzer, one that you breathe into, and it's supposed to pick up the virus in your breath. That has struggled to get regulators' approval because it's not very good. Over.
Okay, yes, thank you very much. We noticed the news also that Singapore is using breath analyzer to detect COVID-19. And that is our policy question also, can we use that? And I think Dr. Kamnuan has a question for your presentation. Please, Dr. Kamnuan. อาจารย์คำนวณครับ
Thank you, Alex. It seems that your government would like to promote using self-testing more regular among Singapore citizens. I wonder, is there any obstacle that people don't want to use self-test? For example, I heard from my colleague that tell me, if you have a very mild symptom, don't go testing, because once you test positive, you will get into trouble because you have to be isolated for 2 weeks. And then your family, your friend also have to be quarantined for another 2 weeks. So don't go testing.
Yeah, you're exactly right. Yeah, I think that is a problem with some individuals. I know when the university launched the self-testing scheme, so many of my colleagues were really angry about having to do it. And at first, I think I was a little bit reluctant as well, although I've done the test now 2 times and it's not too bad. So I think that you're right, that there is a disincentive to testing. And we found that in particular earlier in the pandemic, where the average time from onset through until diagnosis was almost a week. That time from onset of symptoms to diagnosis is much quicker now. I think it's like 1 to 2 days. But that's the ones that we know about. So we're not sure about the cases, obviously the people who are infected, but who we were not able to diagnose them. So as Li Yang mentioned, Singapore is moving towards a lighter touch for isolation and quarantine. So cases which are younger or vaccinated or both, they will be now pushed out of hospital or out of community facilities towards home-based isolation. That's partly because we don't have enough space for them all, but I think also because in a population which is very highly vaccinated, there's less benefit to having people with mild symptoms being quarantined somewhere for 2 weeks, which is what we were doing before. So with that, we're also going to be quarantining people for less. I think it's either a week or 10 days now. And so the idea there is that you can have people recover at home, you can have their families quarantined at home. If everyone is vaccinated and no one's going to be at risk of severe disease, then that would be probably quite a safe approach. And at the same time, by making it less of a burden to be isolated or your family to be quarantined, then we're hoping that that will help to encourage testing, especially the self-testing amongst people who, let's say they've got a small runny nose or something. You don't want to go to a doctor to get tested just in case you would be sent into hospital. But now you can at least do a quick test using a test that you bought in the supermarket and then see if you're all right. So I'm hoping that that will help to encourage more, I don't know what the word is, more pro-social, good behavior from our population. Over.
Thank you. There is additional 3 questions. Do you use the antigen test to identify patients for isolation or for home isolation?
Okay, so at present, if you go to a GP, they give you 2 tests. They give you the antigen test and the PCR test. And so if you're antigen positive, then that's you going to be sent for isolation. Now, I don't know, because we've just changed the rules. I don't know if that's home-based isolation. No, I guess it will be, or hospital-based isolation. If you are antigen negative, then you would be sent home, but not for formal, strict isolation, rather just to wait for the PCR test results, encouraged not to go out and meet your friends and so on. And that's so that if you get the PCR test results 1 or 2 days later, then you can confirm it. So it's an expensive strategy because it means you're doing twice as much tests. You're still doing a PCR test at the point of care, but that which should reduce the risk. Now, an alternative would be that you just do an antigen test, and then if the antigen positive, then you do a PCR test. So then you're going to be missing out some of the actually infected patients who, because of the imperfect sensitivity, are not getting picked up by the antigen test.
And Dr. Chochai raised his hand. I would like to ask Dr. Chochai to ask his questions.
Thank you, Alex. I'm Dr. Chochai Nominee Malert from Sirat Hospital. Thank you for your very interesting presentation. May I ask you a question about in your model, because as you know that the antigen test, it totally depends on the pre-test probability of the patient who gonna get this test done. And the sense and specificity, it depends on the stage of the disease that the patient will, when they have the test. For example, pre-asymptomatic or the first weeks of the symptom. In Singapore, in your model, do you have a plan to use the algorithm like the close contact of the COVID patient or the lifestyle to identify the pretest probability on individual patient and also the state of the symptom that they have, and then come out with a positive predictive value of individual patient, so that we can more precise to use these kind of tests to manage the diagnosis of the patient. And the second question is that in your model, because the tourists, they should not have any symptom. That means they are asymptomatic. So what kind of sensitivity and specificity that you use in the model? Because most of the lab, they use the patient that have symptom to come up with sense and specificity. Thank you.
Yeah, thank you for the very good questions. I'll start with the second one. That is actually quite a big limitation. Actually, for both the PCR and the antigen test sensitivity curves, in that these have, as I highlighted on the slide, these are derived from people who actually were PCR positive, and presumably they had some symptoms, and that's how they were found from earlier in the pandemic. So the actual sensitivity for asymptomatic cases is different, and well, it may be different, and we don't know what it would be. So in that sense, the results could be considered to be optimistic and not conservative. Now, for the first question, it's an interesting one, because at present we are still treating antigen test as the silver standard, not the gold standard. So anyone that we want to diagnose as an actual COVID case, they would be PCR tested. So anyone who's testing positive in antigen, they don't count to our national numbers because we would be giving them another PCR test. So I think because of that, the specificity is probably less of an issue. What I mean by that would be that if you, let's say that we're finding an extra 100 cases a day from antigen tests, but they're not actually real cases, then that means that we're going to have to do 100 PCR tests to confirm that. In the short term, that's an inconvenience to them because they've got to wait for 1 to 2 days to get the PCR test result. To the economy, it's slightly costly because we lose our productivity and we got to pay for the PCR test. The country's paying for the PCR test. But in the grand scheme of things, that's quite a small impact. There'll be situations where it's not. For example, if you're not able to fly because before you board the plane, you test positive, but it's a false positive, that has a bigger impact on people. But we think that everything within the community, the impact is probably a little bit less severe. So because of that, I don't think that that we've seen a value to working out the pre-test probability for specific situations, and thereby to work out the post-test probability that the case is actually infected or not.
Yes, thank you. But
Yeah.
in situation in Thailand, I don't think that we have enough facility to do the PCR test for a lot of number of patients. So we may require the antigen test to screen the patient as far as possible and identify the patient and then containment of the patient. In Thailand, in my opinion, I don't think that we can do the PCR test for all for the high risk of the patient. It may take a lot of time, and also practically it may be quite impossible.
Yeah, I thought I would show this slide again, which has the 2 sensitivity curves that we use in the models. And I wanted to highlight in particular the PCR test. So if you look towards the right-hand side of that curve, it takes a very long time to drop to 0. And that's something that we've seen in practice last year when we were doing mass testing using PCR, that we would find a lot of people who are they're testing positive on PCR when and they're asymptomatic, but they're testing positive on PCR. And then, like I said before, that we test them on serology, we find also serology positive. So this is someone who has recovered already, but there's still viral fragments up the nose. So in that case, is that a true positive or a false positive result? And it's not clear to me that that should really be considered to be a false positive. It's also not clear to me whether a person tested at the same time using an antigen test and testing negative, should that be considered to be a true negative or a false negative? Someone who was infected a month ago, they're not contributing anymore, and yet they could still be testing positive on PCR. So I think that's probably going to be more of a problem when you have large amounts of community transmission, because then you'll be finding more people who you may want to isolate, but actually they long since recovered from their infection. Over.
Alex, there is one question relating to your last slide. I mean, that's slide number 17. One question from Dr. Yod. He is asking if the peak of sensitivity in this picture is reduced to 50 to 60% sensitivity, which is close to real situation in field tests in Thailand. What do you think? Do you think the sensitivity going down to 50% or 60% is going to be a problem with the model that you are using?
Okay, so I'll say yes and no to that. So first, obviously the results, like the numbers that I've got in this table, those results are not going to be the same if the sensitivity is different, right? So we'll need to recalculate that. But the finding that that repeat testing can reduce transmission, I think that will still hold. The question is really just how much will transmission be reduced by it. So the first thing is obviously nothing happens if you don't isolate after testing positive. So there needs to be a system after the test positive that the patient or the person will not contact other individuals, or that they'll have a reduced contact with them. So having repeat tests, actually I'll show you this. This is a better one. So you can imagine having tests done every 2 times a week, right? So 3 days, 7, 10, 14, etc. So even if the sensitivity is 60%, then you would still find them after a number of tests. So you're going to have picked them up sometime before they get to their average of 5 secondary cases, which is what we think the reproduction number would be for Delta. If you pick up someone halfway through, so that you pick them up after 8 days after their infection, right? So it's still a delay, but that's reduced transmission by half from that person, right? And so that may not be enough to stop the epidemic, but it's going to slow the epidemic a lot. And I think that it seems to me that right now, a lot of the countries in Southeast Asia, what they need to do is to slow down transmission in order to get more vaccine rollout. So it's like buying time for the vaccine. So in that sense, I think that it possibly, it could be that it is still effective even at a lower sensitivity. And this is not just something that we found. Other modeling studies, Michael Mina's work in the US, that's also suggested frequent testing with a less sensitive test can still be very effective.
Thank you very much. The next question in the text, in the chat box is it's about I think it's about the PCR test, antigen test that you provided to each household. It was in the news, and I think the question is that how many tests that you distribute in the mass distribution of antigen tests? Because you said that every household has some numbers of antigen tests, but how many tests that you distribute? and
Yeah.
how frequent it is distributed.
Okay, so my household has not received the tests yet, so so I don't know I don't know what goes into the package, but I know other people who have received it. It's supposed, and I don't understand the logic to this. It's supposed to be 6 tests per household. I don't know why, because a big household would need more tests than a small household, but for some reason they're giving the same number of tests to each household. And because I've not received the package yet, so I don't know what the instructions which are provided in it. I think it's meant to be used if you are worried that you've got COVID because you've got a runny nose or some other symptoms, or someone in the house has got a cough or something, then you'd say, okay, let's use the antigen test, everyone. So I think that the strategy about the frequent testing is still one that is still being worked out at present. So, for example, I mentioned before that NUS, the university, has given out test kits to all its staff and students, and we're supposed to test ourselves regularly with this. But that was part of a pilot test. So we all got 2 test kits. So I've used my 2 test kits already. And what we're expecting will happen is that over the next few weeks, the university will announce the long-term strategy for testing on campus. I guess it will be either once a week, once a month, depending if you're vaccinated or not, or once a week for everyone, which would be my preferred strategy. I think it's still evolving quite a bit, partly because we saw the community cases going up, and so the government is trying to work out ways to get it to go back down again.
And how many households that's going to get that test? I mean, how many households in Singapore? Like 1 million or?
It should be about 1 million, maybe a bit more than 1 million.
Okay, thank you very much.
Yeah.
And the next question is about the ATK use strategy. Should be supported by franking strategy, such as the use of PCR confirmatory test, self-isolation versus hospitalization. Would it be possible to summarize what would be the priority of franking strategy?
Dr. Surakemet, can I ask my question, because I think it will help Cecilia's question.
Thank you very much.
To be better elaborated. Alex, I don't know how much has been the discussions or decisions on what I would call population-based ATK use as a control strategy. In other words, how confident are we to do what I call regular ATK testing or proactive ATK testing among the population as a control strategy to minimize transmission? Because as Cecilia has also added her question, if that is the case, ATK alone is not enough. You need other measures as well. For example, treatment or isolation. And you cannot depend on voluntary isolation. It has to be mandatory, because you believe that you invest in ATK in order to start a process to isolate these cases. But I think this is one of the most crucial questions for countries to consider, whether the use of what I call population-based ATK should be adopted, and what else should be done, as Cecilia has asked a question about franking strategies.
Yeah.
But I have another 2 observations. One is that when Dr. Lee was explaining about the so-called overall control strategies, where the government mandated what I call conditional use of public facilities. What are the conditions for you to go to the restaurant and so on and so forth. There's always a mention about vaccination certificate. I was wondering whether Singaporean government is also considering using ATK test result as another certificate to ensure that the one who enter the premises are safe from spreading diseases to others. Should it be used or should it not be used? Because then it becomes what I call policy of use of ATK rather than voluntary. And then, of course, there is another context that I saw as so-called policy related, which is what you have already mentioned about the port quarantine, the port of entry quarantine, which I agree that maybe ATK could have a place if it is sensitive enough. And the question is whether the test use is sensitive enough rather than just using the PCR or don't use any test at all. So I see there are at least 3 settings where you can use ATK from a policy point of view as a mandatory measures. But I was wondering whether Singapore has been doing all 3. The port quarantine thing that you mentioned, is it already adopted that you can use ATK in place of PCR in terms of certificate for safe entry? Are you using ATK in addition to vaccine certification? And then, of course, the most important one is, are you doing population-based ATK? And in that case, what are the other franking strategies that you have been adopting as well? Thank you, Alex.
Okay, thank you. Let me see if I can answer all questions. I'm afraid that I may forget one of them later on. Okay, so the first I wanted to tackle was about the confirming your status when you go to a public place. So Liang mentioned this, and I've got the slide here, which has got a screenshot of the app, which is called Trace Together. So almost everyone in the population either has the app or they have a standalone device, which is about the size of a keychain, key fob, and these send out Bluetooth signals to each other, and so when if you become in a case, then the contact tracers can pull out what's the ID for the people that you came into contact with. So they can do quick turnaround for the contact tracing. Now that has got some other features built into it. One of them is called safe entry. You can see that there. So when I go into a supermarket, or when I went to the pharmacy to buy my antigen test, I click on scan QR, and I've got to scan a QR code outside the shop and then show that to someone who's working security at the shop before I'm allowed to go in. So most people will, if they've got the app, they'll be using the app to scan in. And if they don't, they'll be using their little device to check in using some scanner that's there. So this is it's very common. If you go to a restaurant, they'll ask to see, they're supposed to always ask to see the app or to see your device. And if you show the app, it shows your vaccine status, and you can see that it doesn't yet have test status. That's all in gray, but they're already thinking about how they're going to do test as part of this app. So that I think that in future, it will be like the universities one, where you have to scan into the app to show that you are still negative within a period of time. So I would expect to see something like that over the years ahead. Now, I don't know how long we'll be running it for. And it could be that when we move into the fully endemic COVID era, that we won't even bother using contact tracing app at all. But I think that at some point we probably will have test status, possibly as an alternative to vaccine status within the app, but we're not quite sure yet. Okay, so that's one of the questions. Now, the first of your questions was about population-based mass antigen testing. So I would say that so far, this has not really been done because as you heard, they've only just sent out these test kits. I mean, I have not received mine yet. But we do have quite a few examples whereby we have mass testing, but that has mostly been with PCR testing until now. So I can give examples of this. The foreign workers who they have to do their once every 2 weeks. They got to go and get their PCR test, and that is done at their residence. So these are in a residential community for the foreign workers. There's about 5,000 men living in this dormitory, and so we're able to send a team to do the PCR test on them once every 2 weeks. So antigen test is being used as a supplement to that at present. I actually don't know whether it's being done by a healthcare worker or by the foreign worker themselves. We have other routine testing of people who work on the ships, for example, people who work with the care homes for the elderly, people who work at the airport, other people with a lot of contact, like bus drivers, for example. They're getting repeat tests. And this has mostly been through the work site rather than through the home. So far, most of the population-based testing has been workplace oriented, right? You can imagine the bus companies, we've got 4 or 5 bus companies in Singapore. So when the drivers go in the morning to pick up the bus that they're going to drive about, then some of them would be rostered to get a test done that day, and then we'd have the test done on site. So that would be one of the opportunities to do antigen testing in a supervised fashion. It's almost like DOT for TB, right? So you got to directly observe testing to show that it's not just you doing the test and coming up with a negative result. So home-based testing, which is what the university does, is very open to abuse, and we're not sure how reliable it's going to be in the long term. Okay, now the third question was about people flying into the country and whether the antigen test would be reliable as an alternative. So I'll show you the scenarios that we were looking at. If I can work out how it changed. Okay. Okay, so here's one of the scenarios that we're looking at with antigen tests. So with this, you can imagine that if the on-arrival test is done as an antigen test, then you're able to bypass any concerns about the person doing it by themselves. So, and actually Becton Dickinson came up with a really great system. They didn't get it, Singapore government didn't buy it, but it was a nice system in theory, so that the antigen test would be done by a nurse or healthcare worker at the airport. They'd be sitting in like in a hall or something waiting for the results. The results are all computerized, so that then they get an announcement to say that they're safe now to leave and go back out into the community. So that would give you an opportunity to do testing, which is still done by a healthcare worker, but it's an antigen test. And that's not what we ended up doing, because as you saw from the set of on-arrival testing, it's all going to be PCR, but PCR plus antigen for higher risk countries. Right, so Singapore government didn't go with the antigen testing there. The rationale for that is that then you still get a healthcare worker, but you can wait, you can afford to wait because everyone's going to get some quarantine. We don't know at present how this part, the self-testing, how effective that's going to be, because it could be that I don't know, like you don't put it up the nose very carefully, or you do it very quickly or something. So there's a risk that might not work out well. This has been quite a recent change. So you can see the date there is August 19. So I don't think we've got a lot of results yet to be able to say how effective it is in practice. Does that answer the 3 questions?
Yes, thank you, Alex. We could discuss a little bit more on detail, but later.
There is additional questions about the role of antigen tests in school reopening in Singapore. Is there a role of ATK?
Alex, can you hear?
Alex, can you hear us?
Okay, sorry, yes, sorry, no, I can't. I didn't understand the question.
Oh, sorry. Is this
Yeah,
in
sorry.
the chat box from Dr. Yod? It's about the role of self-COVID test in school reopening policy in Singapore.
Oh, okay, yeah. Okay, I understand, yeah. Okay, so this is one I cannot give you a good answer to, but I can give a partial answer. So apparently, all primary school kids are supposed to get an antigen test before the schools go back. I think they're on holiday just now. But I haven't heard any specific details about that. So I don't know, is it a test that they're doing at the school itself, or is it a test that they're doing at home before they proceed to go back to school? I don't know whether it's a healthcare worker or the parent that does it.
Okay, thank you very
Also,
much.
bear in mind that actually most of our secondary school children are vaccinated. So the question now is really about the primary school children.
Thank you very much. That would be useful for us also. I think we are going to an end of this webinar, and I would like to summarize what we have been discussing for around 1.5 hours. We learned about the COVID situation and control in Singapore from Dr. Lee Yang, and we know that antigen test is one of the toolkits that is going to be useful in the COVID, living with COVID setting. And Dr. Alex also give us information how Singapore used COVID antigen test in Singapore setting. And there is several settings that antigen is going to be useful. And I would like to summarize what we are seeing our outbreak in Thailand. And this is the simulation of the outbreak in a market. We can see that in Thailand, we have right now a lot of market outbreak. And what it means, the market outbreak, is this usually happen with the merchants in the market reported to have COVID and their foreign immigrants workers. And it is linked in the upper layer is the place that migrant worker is living. Migrant workers, they usually live in the dormitory next to the merchant's shops. And they stay close together, one floor, maybe 20, 30 persons sharing one bathroom. And each floor, many migrant workers from many shops stay together. So once the outbreak is happening in one restaurant, it's going to coffee shop, vegetable shop, supermarket, all over the place because they share dormitory together. And then the owners of the restaurant is Thai people. They stay in family home. Some family is very big. They have grandparents, siblings, their grandchildren. Grandchildren go to school together and extending the outbreak to the school. And the nearby working site also contribute to the outbreak. And if there is factory included, there is another link to the outbreak. And the hospital that stay next to this community also get hospital outbreaks. That is how it's happening in Thailand right now. Probably we have to figure out how antigen test is going to be useful in this different setting, because each setting is controlling by each organization. They have their own policy, but it has to be combining together to contain the community outbreaks. We learned from Singapore that we can use this for migrant workers. We can use this for maybe dining in setting, combining with the vaccination status. we probably use it for working site and maybe reopening of the schools. But it has to be figured out. And if you are interested, we are going to have another session for sure to follow up with this antigen test kit. It's going to be with us for maybe next 6 months or 1 year. After we can living with COVID-19. So thank you very much, Dr. Alex, to contribute your knowledge and experience. We hope that we can learn from each other and come up with a good strategy for Thailand and Singapore and Asian countries. Thank you.